You all ready, Kelly, for me to introduce you?
To rumble, Marty.
All right, let's do it. So, good morning, folks, and happy Friday. Welcome to Friday Chalk Talk. Today, I have the pleasure of introducing to you Kelly Campbell. Kelly began her nursing career in home care and hospice and transitioned into her NP career here with us, with our palliative care team with Advocate Aurora 6 years ago. She holds certifications in both hospice palliative care, as well as being a certified case manager. Kelly is going to lead us in a discussion on fatigue. And the format today will be two parts, a presentation, and then we'll open it up for a little bit of discussion at the end. So Kelly, thank you for being here with us this morning. I will hand the mic over to you.
Well, thank you very much, Marty. I think fatigue is a very appropriate topic for me specifically today. It's been a long week, not a great night's sleep. So I'm raring to go with my full-blown fatigue on board with me as well. I did this presentation for a group of NPs here at Aurora, our group, I think maybe 4 years ago. And so I'm kind of dusting it off and freshening it up for the group today. It's important to understand how fatigue can have a negative effect on our quality of life. I think all of us have been fatigued. Certainly, I'm going to just talk a little bit about the different types of fatigue, a couple screening tools, which I'm just going to scan over, and then focus mostly on the pharmaceutical and non-pharmaceutical interventions for fatigue. Fatigue is obviously a very prevalent symptom for people with advanced illnesses or serious life-threatening illnesses. It represents, it's a protective response when our body is tired physically and mentally. And often this is relieved by rest. We get a good night's sleep, we wake up and we're ready to go. For palliative care patients, obviously, this is not always the case. They do not get the relief from the fatigue from the benefit of rest as a normal healthy person might be. Differential diagnosis is always important, of course, anemia, dietary considerations, medication side effects, and other disease states. I'm just going to pop through a couple quick disease states here. I got my little guy without any skin on here. So ESRD, 13 to 100%. That's a lot. That's a lot of fatigue. COPD is up there as well with 32 to 96% of people with COPD experience fatigue. CHF is another big one, 42 to 82. Of course, cancer, that one goes all the way to 100 like the ESRD, and I'm sure that depends on, treatment dependent and whatnot. Dementia, 22, and AIDS with the 43 to 95% as well. This is just a couple of disease states with their numbers here. The different types of fatigue is just clinical fatigue, generalized weakness, easy fatigability, even mental fatigue can be an issue. Some of this could be distinguished as, somnolence, dyspnea, muscle weakness. You might have a patient tell you that their functional status has gone down, and that's really related back to fatigue. We have the chronic fatigue, which lasts for longer than 6 months. And then we have cancer-related fatigue, which is secondary sometimes to the use of the chemotherapeutic agents, radiation treatments, and tumor growth as well. Next, we're going to talk about a couple of quick, I have two, I believe, the Edmonton Symptom Scale. I know some of you have probably seen this. I used to embed this in my note, but I felt like it was just a little clunky. So I just kind of keep this on the side and review it that way. But this is a really nice, when you're having people sort of rate, you can literally print this out and hand it to a patient and have them rate their fatigue. There's the brief inventory fatigue. This one's a little easier, quicker for patients to use. I have 4, I lied, I said I had 3, and then the PHQ-4 as well. So, and that's part of a depression screening that's kind of trimmed down. A couple treatment options for fatigue include the non-pharmacological options, pharmacological options, and medical options. For physical physiotherapy, exercise, I think is important. And the last thing anybody wants to hear when they tell you how tired they are is they need to exercise. We've all been there. We know we get up, we go ride that bike, we come home, we feel better, but boy, getting up and doing it is really hard sometimes. But it certainly has been found. I do have a couple of studies listed up here under the exercise, it was a really good outcome for relief of fatigue with exercise. Physiotherapy, such as physical therapy itself, also had a significant reduction in severity of fatigue when they underwent that treatment. Another thing is interventions related specific to education. It really had a small effect on reducing fatigue intensity. It had a moderate effect in reducing fatigue distress. I know that, when we're tired, it's like a snowball going downhill, and we feel like I've really got to be able to get myself going here. And then you become more stressed out about being tired, and that stress just really makes matters worse. But the educational information that we can provide for patients about fatigue isn't really a huge impact on the outcomes of changing their fatigue. I would say as part of a multimodal program, it might be more effective than just alone. Of course, there's music and acupuncture. The acupuncture, I'm kind of jumping here. There were 7 random controlled trials that showed that they really didn't have good conclusions of those studies. And I think music and relaxation for a lot of us is kind of a go-to when we're tired, is to just kind of meld into that and just sort of regroup our mind and our soul. And so that one was did have a significant difference in the studies that I did look at for this. Some cognitive behavior intervention is another non-medical guided imagery. We're talking about consumption of calorie-rich foods, the exercise again, brief naps, prioritizing the things that you want to do in your life. Teach the side effects of medications. Sometimes we see folks taking some medications in the morning when maybe they should be taking them at night. A good example might be Zoloft, where they're taking that antidepressant every day, and then they're really tired. We're like, well, why don't you try taking that at night? It might actually help you sleep and, give you a little more energy during the day. Distracted methods, and then also monitoring and tracking of symptoms to see if you can identify. So the pharmacological options are essentially pretty limited. We have some options that we can use here. Corticosteroids, and I don't really feel that these are long-term options for fatigue, but when you have a cancer patient that's trying to sort of muster up the strength to attend an out-of-town wedding, or you have a goal of doing something when you're fatigued, whether it's heart failure or whatever, that can we, utilize some medications on the short term to help them feel better for a short period. Corticosteroids, of course, can work, but of course, there's a high side effect burden. If you have, issues with sleep, it can have issues with your blood sugar, your immune system. So, that's not a great thing to have to use long term. There is some good research underway for vitamin D. I didn't go into a great deal about the research here. Of course, up here in Wisconsin, we all need some vitamin D. So, and if it's going to make me feel less fatigued, that's a very low side effect burden medication. We do have the psychostimulant drug class, the methylphenidate, Provigil, Nuvigil, these types of things. Again, these are medications to use to, just kind of stimulate the brain a little bit and keep people moving. But that, I think, can have some negative side effects too, because while you're awake and alert and want to do more, you may be really burning up your resources from a physical perspective. Also consider the concern that you may have a very awake brain and a very exhausted body. And boy, when that happens, the last thing you want to be doing is up all night because you're on methylphenidate and you can't sleep, but you're up during the day moving around and doing, being able to do more. Obviously, there's going to be some contradictions for these medications as listed here, with the cardiac issues and psychiatric issues as well. We want to talk about some possibly reversible causes of fatigue. Cognitive, we have alcohol and substance abuse, which sometimes people turn to prior to clinical illnesses or chronic illnesses, or because of. We have some folks with some sleep hygiene and insomnia. And my dad was a heart failure patient, and boy, the guy would sleep all day and then complain about being awake all night. And so that was a tough cycle to break. And so how can we help these folks try to get into a better sleep cycle to try to reduce that, exhaustion during the day? Of course, we always should address depression, which can have an effect on just feeling fatigued. Um, are medications causing problems? Or do we have somebody that's on, certain analgesic, hypnotics, beta blockers? This is when I talked about, the timing of the medication. Maybe morning's not the best time to take that beta blocker. Are you having some drug to drug interaction? So certainly, review those meds with the patients and say, I see you're taking this with this. I would elicit the help of my local pharmacist. If I have a patient that has a lot of fatigue, and say, here are the medicines I think could be problematic. Can we maybe adjust some of the times that a patient's taking these? Or is there a drug to drug interaction issue that could be having an effect on this problem? The third possible reversible causes would be the correction of imbalances. Obviously, anemia is a big one. Are they kind of on that bubble, needing to review for blood products? I think this is more appropriate in an outpatient setting. I think during the hospitalization, we're drawing blood constantly on these folks, and we're pretty keen of this. But if you're doing an palliative care in a different setting, and you're seeing this kind of trend that's toward more fatigue, is my patient anemic, and do I need to check that? Cardiopulmonary disorders, if you remember the slide with CHF, has a very high, up to 80, I think up to 82% fatigue, if I remember correctly. Putting on some more fluid, is my fatigue worsening? Obviously, fluid and electrolyte imbalances. Is there an infection that we need to look for, keep an eye on, treat? And changes in caloric intake can be a big thing. I think, for us in palliative care, when our folks are entering that sort of realm of the end of life period, whatever that looks like, and they, the kind of the eating goes away. I had a lady that was here just this week, and she said, well, I haven't been behaving very well. And I said, what do you mean? She said, well, I haven't been eating. I said, what do you mean you haven't been eating? I haven't had anything to eat in 2 weeks. So certainly that's going to lead to fatigue. And then so we want to explore that with a patient as well. So what can we do? Assess the baseline fatigue scores. I gave you, I think, 3 tools. There are plenty out there you can look for. I think CAPC has a module on fatigue as well. Recommend increase in low impact exercise is tolerated. Of course, this is going to be age and disability and disease dependent. If you have an end stage COPD that's 85 or 90 and they're really retaining a lot of fluid, this is going to be really difficult for them. Music therapy, I love for everybody, no matter how they're feeling. Alternative, methods of just treatment, aromatherapy, these types of things. I'm a big believer in that. I especially, I think that's more for the anxiety, but, sometimes it just helps to have things, if that's something that you feel or your patient feels would be helpful. Here at Summit, we use it quite a bit. It's nice to come on a unit and smell something besides body fluids. And so I think that helps a lot. Assess and treat vitamin D deficiency. Again, as I talked about earlier, Wisconsin, in the northern states with a lack of sun, I'm sure most of us run a little low. So we want to make sure that we have optimal treatment of that vitamin D deficiency. Consider stimulants for chronic fatigue or short-term target as needed. Again, as we talked about, is what can we do to help somebody through maybe the weekend when the kids come, or maybe for an event or something. Again, this is long-term stimulants is not recommended for fatigue for multiple reasons, as already discussed. And we talked a little bit about education on fatigue has, a pretty low change in fatigue, but I think it still is part of a multimodal program to address fatigue. suggest support group or counseling if necessary or available. So that's kind of my little spiel. I took a pretty big slideshow and really squeezed it down. I wanted to make sure that we were cognizant of the time. So, and I have a little reference slide here. I'm not sure, Marty, if we make these slides available after this or not, or just they rewatch the video.
All right. Thanks, Kelly. Let's open it up for some discussion or any questions. And I wanted to add one thing before we did. I know in the more recent version of the Unipack that it talks a little bit about how the most recent Cochrane review didn't really show a lot of great evidence for any of these pharmacologic treatments. But that was back in 2015, and I know that there are always new studies coming out, and so there may be room for some new evidence. When I thought about your presentation back in the fall, there was a study that came out of Denmark that was in the Journal of Pain and Symptom Management that looked at what you were talking about, sort of the short-term or PRN stimulants, and they were giving methylphenidate as needed instead of more traditional scheduled. And it was a small study, only had 28 patients, but it was a positive study. And it did show some benefits. And whether or not we'll find that to be the case longer term or with a larger study, I guess, is to be determined.
I'm wondering what people's experience is with going through some of these interventions in the inpatient setting. Personally, I struggle with that, knowing that I'm probably going to see these people for a couple of days and then they're going to leave and be handed off to another provider. And so I'm a little reluctant to start really attacking something like fatigue because it is a longer term problem often. I'm just wondering what people's experiences are with that.
Well, I certainly like to loop in my primary cares. I loop in my primary cares almost any time I do a palliative care consult and send the consult over. If it's somebody that we have very specific, I would also be very leery to start anybody even on a PRN methylphenidate or anything like that, but make the recommendation to primary care and say, I think the patient might benefit from this on a short term or as needed basis, but I'm not going to, start that here in the hospital. So definitely looping in either, or we have our palliative care NP over at our VLCC, our cancer clinic, loop Denise Anderson in if she's part of the patient care, loop in the oncologist who's, they're all, dabble in palliative care all the time anyway, but definitely the primary care, not just sending the consult, but sometimes sending direct recommendations to them as well for some follow-up on the outpatient side. I agree it's tricky to get a lot done here, in the inpatient setting.
Yeah, I feel the same way, Kelly. At Luke's, probably 95% of our consults are goals of care. So I'm not dabbling in a ton of symptom management, but when I do, I often will send a secure chat to the PCP before I make a change and say, hey, I'm thinking about this. What do you think? Are you willing to follow this and, watch for some side effects in case that does happen? And that's been, yeah.
That's the same here, a lot of goals of care discussions, but I'm always kind of a little excited when I get consults for a symptom management. It actually puts a little terror in me because I'm like, oh my gosh, what am I doing now? And the truth is you do know what to do, but because we don't do that as much, it's a little out of our wheelhouse. So we got to jump back into it. But I try to find recommendations that are medical, even on my goals of care discussions, because I want to keep my hand in that.
All right, guys. It's just about 10 o'clock. Anything else before we wrap up for this beautiful morning? All right. Sounds great. Thank you, Kelly. We really appreciate you being here today and giving us an overview.
Thank you for the format. I appreciate it. Have a good day, everybody.
You're welcome. See you later. Bye.